Hello everyone. My name is Grant Turek. You may recognize me from some of the previous talks, but I would actually like to take this time to thank you for attending. Also thank the AADMD and the ILAE for helping us put on these talks. But I'm going to pass this conversation over to our moderator, Shaker, who will be leading our conversation today. So, Shaker?
Thank you, Dr. Turek, for introducing us. Just wanted to welcome everybody to this webinar. My name is Shaker Dukapati. I am a fourth-year medical student in the MD-PhD program at the University of Nebraska Medical Center. And I have a research interest in working with adults with intellectual and developmental disabilities. I'm also a sibling of an adult with epilepsy, IDD, and motor challenges, and part of the ADMD chapter here in Nebraska. Today we're going to have a webinar. This webinar is going to share the experience of diagnostic and treatment or assessment options for individuals with IDD, discussing the roles of genetic tests in adults with IDD, as well as the rationale for considering genetic testing, the use of epilepsy gene panels, and benefits of precision medicine. And today I have the privilege and the honor of introducing our panelists. First, I'd like to introduce Dr. Suki Ko. She is Professor in Chief of Pediatric Neurology at Children's Hospital and Medical Center here at the University of Nebraska Medical Center. She is also my professor, and really glad to be able to introduce her. And also, I'd like to introduce Lisa Monaster. She is the co-founder and president of the CACNA1A Foundation, which is a parent-led nonprofit organization that works to find specific treatment options and cures for patients with CACNA1A related neurological disorders. Importantly, Lisa is also the mother of an adult with IDD and speaks from that experience as well. So really glad to have both of them join us today. So what I'm going to do is I'm going to be moderating the chat. So they're going to be presenting and if you have questions at any time, please feel free to put it in the chat. I see a lot of introductions from a lot of different places around the country. But first, we'll have Dr. Ko speaking. And if you have questions at any time, please feel free to use the chat. Thank you.
Good morning, everyone. It gives me great pleasure to talk to you about assessment and diagnostics in adults with intellectual and developmental disabilities. I will be focusing on epilepsy as essential comorbidities with adults in intellectual developmental disability and the role of genetics. So what I like to talk to you today is to how to recognize and manage epilepsy in adult with IDD, to understand the role of genetic tests specifically for adults with IDD and other epilepsy of unknown cause, and to learn genetic testing strategies. To start, anybody know what this is, this picture? It's our beautiful Earth. It was taken from Apollo 8, and I was told the person who took this picture, this view changed his life, is what he said in 1968. And I show you this to remind you that we are 240,000 miles away from Moon, and our Earth is 24,000 miles around. And since 1968, there has been such advance in our genetics, and just to see the impact of what we are made up of. So if you think of the human diploid genome, which has 6.4 billion base pairs, and if we were to put 2 inches per each pair, our own DNA will string and travel between Earth and the Moon. And it was found by 2011 that all of us carry with us a random de novo, that's our own unique changes, germline mutations, and many more somatic mutation. And it is the, a miracle of the redundancy in our gene that we are who we are and able to function. So what we are dealing with sometimes is one misspelling in a book that has a devastating consequences. And we are at a point where the science have come so far that we are able to detect that one misspelling and be able to give molecular diagnosis. And it's time for us to translate the advances in basic science into a clinical practice. So as some of you may be aware, in 2003, the race to complete the human genome was completed, and it was a Nature publication where two teams, one was led by government, NIH funded research, and the other one was commercial, and they were working very hard for the 10 years, and it cost $3 billion, actually 13 years, to declare success. They were so close. They actually waited for each other to publish, and it was a Nature publication. And so from $3 billion to sequence one individual's DNA. And 10 years later, the average price for whole genome sequencing was $10,000, but in January 2014, that was almost 10 years ago, the Illumina, the biotech company, introduced a new machine that can sequence an entire human genome for $1,000 in about 24 hours. So we've come a long way. And this has allowed us to do actual detecting the misspelling in a book, this next gene sequencing technology. So to go back to the overall view of what intellectual and developmental disability is all about, we know that about 3% of population have IDD. An interesting fact, how it relates to epilepsy is about 21% with IDD has IQ of 50% has epilepsy, whereas 50% of individual with IDD with IQ less than 50 has epilepsy. So when you look at the whole population of IDD, about 10 to 20% will have these comorbidities of epilepsy. Important that 40% of individuals living in a residential facility have epilepsy. And so it's hard to ignore epilepsy, and it will be good for us to know the etiology for epilepsy which also carries the IDD with the individual. And the reason why may be partly explained by this graph. When someone has epilepsy younger than age 3, and there are these clusters of individuals below IQ of 50, the younger they are, the more likely they would have intellectual disability, a profound intellectual disability of IQ less than 50. In addition, if you let the intractable epilepsy go on untreated or poorly controlled, there is this direct progressive relationship between length of intractable seizures and lower IQ score. So if you look at the whole population of people with epilepsy, it really shifts the IQ leftwards. So full-scale quotient, patient with epilepsy, we are seeing this shift toward the left and downwards as the years go by with uncontrolled seizures. So what about epilepsy in patients with IDD? Often they have multiple mixed seizure types. They are often treatment resistant and could be prolonged status epilepticus, the seizures that last over 5 minutes. They can also have seizure clusters. They will sustain falls from seizures. and often requires lifelong epilepsy treatment. And this all, IDD plus epilepsy then lead to the residential life, and there's economic restrictions. Other challenges include being on many different medications, not just anti-seizure medicine, but other medication, antihypertensive, for example, anti-diabetic. And seizures are often poorly witnessed and described, and sometimes we mix the non-epileptic events, such as stereotypies or tics or self-stimulating behavior, misunderstand them as epileptic events and over-treat them. And often the gold standard, of course, is to do video EEG monitoring and but sometimes that can be limited. So I think it's important when epilepsy becomes drug resistant, we need to then think about what is the goal of therapy. In every visit, I think it's important to remind ourselves, what is the goal of therapy? We would like to eliminate the most disabling seizure type. But also, as important is the reduction of the drug side effects, such as sedation. We try to minimize polypharmacy in therapy, provide safe environment, because seizures can be triggered by hot temperature, for example, and focus on the best possible quality of life. And treatment should include consideration of comorbidities and the weight, watching weight, the alertness, the gait, the tremor, other comorbidities, neurological comorbidities of epilepsy and IDD. So it was really the Hippocrates who mentioned this about the genetic influences in epilepsies. He said, I am about to discuss a disease called sacred. It is not, in my opinion, any more divine or more sacred than any other disease, but has a natural cause. Its origin, like that of other diseases, lies in heredity. And I just want to pause here to say there is a difference between genetics or heredity and a condition being inherited. So often when I say genetic epilepsy, many families will say, oh no, but I don't have epilepsy. My partner doesn't have epilepsy. It's the only child. And in fact, when we do genetic testing, what we're looking for is actually de novo mutation. That's something that's new in an individual that are not inherited from either parents. And so heredity here implies DNA makeup. Looking at the genetics of epilepsy broadly, the misspelling that I mentioned in a book really makes up, the single gene epilepsy makes up less than 5% of all families. However, even in clearly acquired epilepsy, we cannot deny there is a genetic influence, such as hypoxia, ischemic encephalopathy, hypoxic ischemic encephalopathy in newborn. Only 25% will develop epilepsy and the other ones won't. So there is that genetic predisposition. Post-traumatic epilepsy, same way. About a quarter of them will develop post-traumatic epilepsy and not the other 75%. Also, there will be epilepsies with complex inheritance. Most common ones are genetic generalized epilepsy, such as juvenile myoclonic epilepsy, juvenile absence epilepsy. We don't know exactly how, but it's a complex genetic predisposition. So with the advance of the inquiry into the genetic causes of epilepsy, what we have found comparing 1975 until now, what used to be called idiopathic, and my faculty advisor used to say, oh, that means the doctors are idiots. We have no idea what causes this, right? From idiopathic, now we are seeing single gene epilepsies, familiar or de novo, but also epilepsies with complex inheritance and epilepsy with modifiers and susceptibility alleles. So we are now having much better understanding of genetic causes of epilepsy. And this is an example of unselected cohort of 339 physician-referred epilepsy patients, and they were just looking at 110 genes curated, And what they were able to find was these common variants. I'm just going to spell out first 5, the SCN1A, sodium channel, KCNQ2, potassium channel, CDKL5, SCN2A, another sodium channel, SCN8A, sodium channel, and it goes down. There's a KECNA1A down here, and these are the relatively common genetic changes that we were able to find in this paper, published in 2017. And looking at the age of onset, and especially for epileptic encephalopathies, we are now very aware these genes, STXBP1, KCNQ2, SCN2A, are responsible for Ohtahara syndrome. And similar gene appears again for West syndrome, the infantile spasm syndrome, and Dravet syndrome, of course, SCN1A, and Lennox-Gastaut syndrome, additional gene DNM1, and myoclonic atonic epilepsy or DREW syndrome due to transporters SLC, 2A1, 6A1, and Linda Krafner specifically with GRN2A. So the whole class of epileptic encephalopathy now understood on the basis of molecular changes. So what is the recommendation guideline? There is no formal guidelines. However, International League Against Epilepsy recommends that there should be genetic counseling for all patients with infantile seizures. So when the seizure onset is younger than 3, I think we need to think about genetic epilepsy. So genetic evaluation and setting of Dravet syndrome and other epileptic encephalopathies. So when there's a severe epilepsy with comorbidity of IDD or movement disorder or ataxia or gait difficulties, you should think genetics. And I like to focus here. The ILAE felt that the genetic testing was a minimum care for adult patients with ID and epilepsy when they come together, and that genetic evaluation should become a standard of component of care. But as I mentioned, there's no formal guideline. So does this happen? But implementation in clinical practice is often inconsistent. So there was a survey that was done on 109 neurologists who were asked this question, and they made up of 76% treating mostly adult patients. So this was a scenario that was given, hypothetical case, an 18-year-old man with global developmental delay and a history of infantile spasms, which led to Lennox-Gastaut syndrome, a prototype drug-resistant epilepsy with multiple type seizures with IDD. An MRI shows some enlargement of the right ventricle, but no other findings. So there are non-specific findings in MRI. So it's not etiologically related. Basically, it's unknown cause. And the seizures are drug resistant. Metabolic testing was negative. And so the question was posed to mostly adult neurologists was, would you order genetic testing? And guess what? Guess what they said? Only 33% of adult providers said, yes, I would order genetic testing. Majority, 67% said, nah, it's not going to make any difference. I would not order genetic testing. Think about this. This is just a hypothetical case, but prototype of epileptic encephalopathy, seizure onset younger than 1 year with infantile spasm, and then evolved into Lennox-Gastaut syndrome with IDD, and they wouldn't consider genetic testing. I think pediatric colleagues did much better job. So 80%, overwhelming majority said, yes, I would order genetic testing. And this is a reality right now. Why would you want to do genetic testing? Right? Because adult providers felt that it was not necessary. I wouldn't bother, is what they said. So I have seen many times that no matter what you say, the mothers would blame themselves, that it was somehow that drink of wine that was led to this problem, right? They almost always want to know why, and they want to find closure. And there were many patients of mine who had undergone not just a repeated MRI, but lumbar puncture again and again. When and there was no reason, there was no etiology found. And now we are entering this very exciting time of clinical trial with genetic manipulations. And so there's more coming, and where they require molecular diagnosis. It will allow for specific counseling, especially for family planning in the future. And many times there is a specific alteration in management that is possible. You actually don't know how you're going to do differently unless you actually find that answer. And Lisa Menester will talk more about what it was like for her to find the answer. And I think that will provide a powerful example why we should consider and do genetic testing in adult with IDD and epilepsy. So one example, two examples where genetic testing and finding an answer will make a huge difference is Dravet syndrome or migrating epilepsy infancy. That's KCNQ2 mutation, but SCN1A, where you could avoid sodium channel agent and makes a huge difference. Glucose transporter deficiency, SLC2A1, nothing else will work but ketogenic diet. It is the way to treat and avoid not just the movement disorder, but the progressive intellectual disability and epilepsy. This is, I find, the best example of why we need to get genetic testing in a Dravet syndrome due to SCN1A mutation, where sodium channel blocker would further what we call haploinsufficiency of sodium channel function. If they were on contraindicated sodium channel blocker for over 11 months, you shift the whole IQ curve to the left. And so this was, I think, best evidence why you should avoid some of and get the answer, molecular answer, and avoid what is contraindicated in that person. Many of these children would have presented to emergency room on status epilepticus while on lamotrigine, while on oxcarbazepine, which could have been avoided. And over time, it could shift that IQ curve to the left. Another example of why gene testing is possible and helpful. So GAPS plus can be due to two different genes, and same epilepsy syndrome. Clinically, they are not different. However, if you had SCN1A, your condition would be exacerbated by carbamazepine. If you have SCN2A as a cause of GAPS plus, you need carbamazepine to get better, right? Only carbamazepine will work. So here you can make decision based on the genetic diagnosis. Also, used to be channelopathy is what epilepsy used to be called, right? But no more. We have many other genes that's coming to view as a causes of epilepsy, the chromatin remodeling, signal transduction, synapse formation, and these are the MECP2 is a Rett syndrome, right? And they have epilepsies often, and so you can imagine many more coming to awareness of different molecular causes of epilepsy and IDD. And the reason why we need to sometimes order gene panel rather than single gene testing is what was found was the clinicians were notoriously terrible at predicting the specific genetic, correct genetic condition. Only 15% the physicians were correct. So it's with humility. We say early infantile epileptic encephalopathy, order gene panel because it could be caused by different genes. And this is a reality. We cannot predict exactly. Although like Dravet syndrome, they have a very specific clinical manifestation. Even then, I think it would be reasonable because included in the gene panel. Another example of extreme phenotypic pleiotrophy, even if you had STXBP1 and that causes Aurora syndrome and early onset epilepsy, some of them don't even have epilepsy, as you could see. And So here, there's only intellectual disability and no epilepsy. And we all know that many epilepsy syndrome can be due to more than, certainly more than one or two. Many more can cause West syndrome, for example. So a gene panel can help elucidate the genetic heterogeneity associated with epilepsy phenotype. This was a study that was heralded by Dr. Enberg, and I was fortunate to be part of it. This was a study done by Pediatric Epilepsy Research Consortium, where what we found was in 40% of patients whose etiology would have remained unknown without testing, when they underwent further testing, we were able to identify pathogenic variant in about 30%. The diagnostic yield were greater than 15%, regardless of developmental delay, spasms, or young age, and yield was greater for epilepsy panels and whole exomes than for chromosome microarray. So sometimes they will say, oh, we did genetic testing. And what they meant was either just the chromosomal microarray, where we are looking at a large deletion and duplication of chromosome, but the yield is 8%, whereas I think looking for that one misspelling in the book, doing the gene panel, the next gene sequencing, and epilepsy panel will yield, or whole exome sequencing will yield a much greater, about 30%. So we often do serum amino acid, blood, urine organic acid, and CSF amino acid, organic acid, carnitine. These are what we consider metabolic tests. And just in comparison to the high yield of genetic testing with next gene sequencing, the yield of the metabolic testing that's done all the time, they are diagnostic in less than 30%. So 3% versus 30%, I think the tenfold difference in yield of diagnostic testing. As I mentioned, the whole exome sequencing was a winner, but close by was epilepsy panel, followed by chromosome array. It is even more striking in the newborns when they start to have neonatal epileptic encephalopathy of unknown cause, when MRI was unrevealing. And if they underwent genetic testing, the yield was over 80%. And here the KCNQ2 was the winner, the most commonly identified etiology. And what a relief that would be to find that genetic cause as soon as you're born, within first month of life, right? So I think it is important to remember that yield can be quite high. So yes, the child was born with the condition. It must be in their DNA. So these are the published result of the epilepsy gene panel and its yield, anywhere between 14 to 50%, quite good. And here the what we call usual suspect, the sodium channel genes, STXBP1, SYNGAP, PCD19, MECP2C, and I don't see Kekana here. Interesting. Here it is. In this particular study, this is all accumulation, every gene testing that were done, at least that were published. So sometimes 8 genes account for 50% of diagnosis. And as we go down the list, that's why there's I vote for the next gene sequencing of gene panel, because you could actually feel comfortable, and whole exome sequencing is the next step usually. So this is the suggested genetic testing algorithm for unexplained epilepsy, especially when they have other comorbidities such as autism spectrum disorder, congenital anomalies, developmental delay, intellectual disability, infantile spasm. I think when you have this combination of presentation, I think genetic testing is highly recommended. Often the chromosomal microarray is done as a screen. If it's not informative, then do epilepsy gene panel. But in a way, when you have when you don't have these, I think chromosomal microarray, the chromosomal changes will be unlikely. So you could go directly to epilepsy gene. And then if that's uninformative, you could then do whole exome sequencing. That is what was suggested in 2016. Some people argue that why not just go for epilepsy gene panel, and if it's then negative, then either do whole exome sequencing and also do microsome microarray. Because now we have 304 genes that's available, and that list is increasing, and it has a high yield doing this gene panel, especially if you have epilepsy and developmental delay and or autism spectrum and other changes. So to summarize then, we all are very aware there's a multiple comorbidities in individual with intellectual disability, in developmental disability, and that intellectual disability is a common accompaniment of early life onset epilepsies. For example, Lennox-Gastaut syndrome and Dravet syndrome. Remember that 50% of individuals with IQ below 50 have epilepsy. And in terms of the treatment approach, be mindful of quality of life and focus on treating disabling seizures and avoid medications that exacerbate seizures or cognition. I believe that genetic testing, including chromosome microarray, gene panel, or whole exome sequencing is indicated for adults with IDD and epilepsy. And with that, thank you very much. And I'd like to pass the button to Lisa.
Thank you very much. I'm going to share my screen now. Okay, can everybody hear me okay? Great, thank you. So thank you so much for the invitation. It's an honor to be here. As Shaker mentioned, my name is Lisa Manister, and I am the parent of a 26-year-old daughter with an intellectual and developmental disability. I'm also the co-founder and president of the CACNO-NA Foundation. So I am going to provide some context on the importance of a genetic diagnosis from both the perspective of the family and the patient advocacy group. I'll touch on my journey. I'll quickly discuss CACNO-NA related diseases and present my thoughts on how a diagnosis can actually make a difference, not only for the individual, but also for the greater community. So first, a little bit more about my story. My daughter, Emily, was born in 1997. And being my third child, I noticed pretty early on that she wasn't developing similarly to my older two children. We saw our first neurologist when she was 6 months old, and she had her first seizure at 8 months old. Over the first 10 years of her life, we saw 8 neurologists, 3 developmental pediatricians, and 6 geneticists, yet her only diagnosis was a global developmental delay and epilepsy. And actually, when Dr. Ko talked about all the different things that parents will do, we even had her go through a muscle and a nerve biopsy when she was a baby, because we couldn't get any, all of her blood tests and all the different genetic testing they were doing at the time was all negative. So nobody could give us a reason for her issues. And in fact, one renowned neurologist, he's often called the father of pediatric neurology, but I won't mention his name, told me I'd never know the cause and to quote, just go home and love her. In 2017, when Emily was 20, after reading an article about the Human Genome Project, I told our neurologist that I wanted to go back and do additional genetic testing. He put Emily into a study on epilepsy genes, and a few months later, we received a diagnosis of a de novo CAC-NA1A genetic mutation. So for me, that diagnosis was life-changing. First and foremost, as Suki mentioned, it meant that Emily's issues were not due to the Benadryl that I took for a rash while I was pregnant. And that was exactly what I had attributed everything to. The massive weight of guilt that I've been carrying around for 20 years just simply dissipated. It also connected me to a community. Of course, at the time, I thought the diagnosis meant her doctors would know how to treat the disease. The medication she took would no longer be trial and error, and perhaps some of her most troublesome symptoms would go away. That wasn't the case. Instead, I was told that there are no specific treatment options for this disease, and I may want to search for a Facebook group. I did, and connected with other parents online. We all had similar questions, yet there were so few answers. So with another mom in March of 2020, I co-founded the CACNA1A Foundation. Since I'm not sure how much you all know about CACNA1A, I thought I'd give a quick overview. The gene encodes for the voltage-gated calcium channel PQ, or CAV 2.1, which is expressed in the central nervous system and the cerebellum. There are both gain and loss of function mutations, which cause a broad range of phenotypes. So the channel opens and closes, calcium flows through, and neurons fire. And the spectrum includes epilepsy, ataxia, hemiplegic migraines, developmental delay, intellectual disability, sleep disturbances, eye movement disorders, and speech and language issues. And there's many more that parents associate with the disease. Due to the presence of cerebellar atrophy, we believe that in addition to being a neurodevelopmental disorder, it is also neurodegenerative. CACNA1A is also considered an autism gene, and many of our patients have a diagnosis of Lennox-Gastaut. As you can see here, there's actually a wide range of seizure types associated with the gene. The data on the left, we have a natural history study that's being organized by Dr. Wendy Chung, who was at Columbia and is now the chief of pediatrics at Boston Children's Hospital. So the data on the left comes from the first 47 patients that enrolled in our natural history study. And the image on the right was presented by Dr. Chung yesterday at a research meeting that we had. And that actually breaks down the seizure types by gain and loss of function variants, the ones that we know are gain or loss of function, I should say. But needless to say, there's quite a large spectrum. So back to the CACNA1A Foundation. We are a parent-led group and are driven by a sense of urgency. It is at the forefront of everything we do. I like to think of the forming of the foundation as a purposeful odyssey. We are on a journey to find new therapeutics and one day a cure for our kids. We are working to develop a collaborative network of our stakeholders, the patients, families, clinicians, and researchers, to accelerate translational research or research focused on a cure. We believe our role is to bring everyone together and give them a voice at the table. We have given out over $300,000 in research grants to date, and we're just at our three-year mark. But we'll only be successful if we can find our patients. As you can see from this slide, CACNA1A is actually not so rare. Based on this prediction, there should be 26,000 patients or so in the US alone. Dr. Chung says we need 500 patients in our natural history study if we truly want pharma to take us seriously. So how can we find more patients? Genetic testing. It's as simply as that. The other piece of information on this slide that I think is really important is that when you look at our natural history study, 80% of we only have 154 participants in it so far, but 80% of them are under 15 years old. But yet we know older patients have to exist. It's just that they're not diagnosed because the gene panels and whole exome sequencing didn't exist or weren't a standard of care when they were going through genetic testing. But the journeys of our older patients can help inform the natural history of the disease. In fact, each time we set up a call with biopharma, the first question we are asked is, how many patients do you have? And it's really hard to say, well, we know there's thousands, but we actually only know of 190 of them. Finding older patients could help us better understand the disease's trajectory or natural history. If doctors could reinvestigate their patients, those that had their first seizures as young children, had global developmental delays, or have a diagnosis of IDD, we know we'd find more patients. So this slide just reiterates what Dr. Ko said about the value of genetic testing. Many doctors do not see the value in pursuing a genetic diagnosis for adults because they're often well controlled and in a good place. But if I can impress one thing on you, it's that for patient advocacy groups like ours, trying to fund translational research and to support our families, adult patients are one of the most valuable assets we have. Understanding the genetic diagnosis could help inform the disease for today's younger patients. We always tell parents that they are sitting on the most valuable resource we have for finding new treatments, their data. Natural history study data helps characterize disease progression, can provide endpoints, and explain treatment effects. The bottom line is that data from older patients adds incredible value and adds to the comprehensive knowledge of a disease, leading to better care and targeted treatments. Of course, it can also affect family planning, and as I mentioned earlier, provides a sense of relief from the uncertainty, and really an opportunity to connect with disease-specific support groups. I told Dr. Koh when we were talking the other day about preparing for this presentation, I told her a story about how after my daughter received her diagnosis from whole exome sequencing, I told 5 friends about it. And 3 of them ultimately went back to their geneticists and had whole exome sequencing for their kids. One received a diagnosis of Kleefstra syndrome, another KCNQ2, and the other SHANK2. All 3 families were able to join communities and support groups organized by the accompanying patient advocacy groups for these rare diseases. And I think there's really something to be said for finding your people who truly get the crazy lives we lead. Most importantly, in one case, the medication protocol was changed, which made a huge difference in that child's quality of life. So finally, I noticed in the chat that there were some comments about the cost of genetic testing. And it is expensive, although the price is coming down, but it's important to know that there are companies that will do it for free. And this is not a plug or, for Probably Genetic, but on our website, we actually have a link to Probably Genetic, and they will provide free genetic testing if they believe you have an undiagnosed genetic disease. So you can go to our website or go to their website, and they have a screener and fill that out. And if they think that there's a genetic cause for an individual's issues, they will do that for free. There's also a program, and I'm sure there's more of them. This is just one of the ones that I know of, but Invitae has something called Behind the Seizure, which will test children whose first unprovoked seizure was before the age of 8. You might actually have to be under the age of 8 too, I think. So thank you very much. This is actually a photo of our family. We had our very first family conference last year and had 35 families come together. We had over 100 people in all. Our next one will be in 2024, and we're hoping for an even bigger turnout and maybe a few more adult patients. Thank you.
Thank you both so much. The question panel here is there's a lot of questions from folks, so I'm going to kind of go through some of these questions, and some of them are particular to one or both of you. So one question, there have been several people to relocate to Colorado to have access to medical marijuana, particularly for epilepsy. The patients and families swear it's a life-changing treatment. My concern for these individuals is finding meaningful and competitive employment when medical marijuana is still part of drug testing for gaining employment. There's a disconnect with policies. For example, opioids are acceptable for pain management, but medical marijuana is not. Being a medical marijuana patient is another barrier. What can be done about this? Are you aware of compelling empirical research that demonstrates medical marijuana is safe and doesn't interfere with job performance?
Perhaps I could answer that question. So when the story broke, I think it was a deadline, the patient who was treated with the very first CBD oil, one component of marijuana, without THC, was a patient with Dravet syndrome. So they knew that she had SCN1A mutation, which then led to the actual clinical trial where there was no precedence, but there were waiting lists for patients to get enrolled in the study. Never happens. So we actually had to limit how many patients we could enroll in the clinical trial. And the CBD, which is nearly 100%, Epidiolex, which was developed in UK, is nearly 100% CBD only without THC. And they have done a lot of research where you can breed the plants to be 98, 99% CBD, and was led to the FDA approval of Epidiolex. So I think that that is absolutely accepted practice, and that should not interfere with any employment or any drug screening. And I would advocate for use of Epidiolex. In addition to Dravet syndrome, FDA approved Epidiolex for Lennox-Gastaut syndrome. So if you carry the diagnosis of Lennox-Gastaut syndrome, then you can definitely get anywhere in the country, not Colorado. And in a way, the CBD, the Epidiolex, the clinical trial led to many states making marijuana available as a medicinary. And I think it lifted many years of almost ban against even the research and use of marijuana. I do feel there's a merit to it, but for at least as a pediatric neurologist, we don't know the long-term effect of THC, and I'll be a little less enthusiastic about medical marijuana, especially the ones that are just available without prescription, because in fact, when FDA collected all the samples of medical marijuana, the content sometimes was so small, undetectable, and we don't know what else is in there. So I don't know. I'm a little nervous about recommending medical marijuana to my patients.
Thank you. Another question, a couple questions from different people on the same topic of testing covered by insurance versus the cost of the testing. This was something that was covered, but how exactly is testing covered by insurance? If not covered, what is the average cost? Are there any cost savings to show that doing genetic testing first is helpful from a health and financial standpoint?
Yes, I think we are becoming more aware and becoming more convinced that genetic testing is not only life-changing, but cost-effective. I think Lisa mentioned the muscle biopsy, nerve biopsy, lumbar puncture. I mean, if you make diagnosis of KCNQ2 when you are a newborn, no more research, no more search is necessary, right? So you stop right there. You have molecular diagnosis. So how can we do it, right? Especially for adult. So this was like a best kept secret. I talked about how next-gen sequencing costs like $13 billion as a beginning, and then it banked down to 10,000, and now it's 1,000. Now, the whole, not whole exome sequencing, but epilepsy gene panel through Invitae can be done for $250. So $250 is all you need if you are willing to pay out of pocket, because the insurance company will still say, we're not going to, this is experimental, right? But I think you should convince the physician, if you're not a physician, if you're a family member, to do the gene testing. And sometimes if you just order it with the buccal swab, we don't even need blood sample, Invitae or GeneDx, the good companies will take care of the prior authorization and insurance issues for you. But if everything else fails, you can get this amazing result. And negative testing is also quite refreshing, don't you think? That you don't have that epileptic encephalopathy gene, that you have an option of possibility of outgrowing this condition. So I think the test results would be so informative, either positive or negative. And if all else fails, you can pay upfront $250 to get 304 epilepsy gene tested. And I think there are also panels for autism spectrum disorder. There's a panel for intellectual disability. There's a panel for hemiplegic migraine. So what used to cost $5,000 for one single gene, now it's $250 for 300, 500 genes in a panel. So I just want you to be aware that it's very affordable, and it can be done, even if insurance company denies the payment. And now many insurance company will actually approve the testing. You don't know until you try.
Thank you. There's several questions from parents who are asking about genetic testing that was done either more than 10 years ago, and questions about, are there benefits of getting a new genetic evaluation done now? Is there reason to seek updated testing due to better procedures in genetic testing? I think we know the answer, but I'd like to hear it from the both of you.
Lisa.
Sure. So we, as an organization, have have partnered with Invitae and also with GeneDx, and for different for different initiatives. And I know GeneDx, and I believe Invitae would say the same thing, that if your genetic test is over 5 years old, there's a lot of value to looking at it again. And I also know that if it's between 3 and 5 years old, you can ask the doctor that ordered it to have them rerun the test, and they will do so at no cost.
Yeah,
so I think it's something that
I think it's for whole exome sequencing. If you have done whole exome sequencing, the interpretation, right? The results are there. The gene doesn't change, right? The information is there. What was available 5 years ago is so different from what we have now. So the genetics knowledge has exploded, and we are learning together, right? And so I think, especially if it's 10 years old, definitely. And what we used to think of genetic testing was just microchromosome. It was a chromosome test, and they said, oh, we're done with the genetic testing. No more. I think we definitely need to do, there's a program in Epilepsy Foundation, I believe, or CURE, Citizens United for Research in Epilepsy, where they will actually allow the retesting of whole exome sequencing if it was done. Just reanalysis.
Thank you. There's a couple of questions about, one question about which chromosome is the most affected. They're wondering about how gene mutations play a role in patients with Down syndrome. Are there any genes related to late onset epilepsy?
There seem to be some predilection for certain chromosomes. So 15q, for example, we see a lot of 15 Q chromosome. 21, we call it catch 21. 21, I think chromosome 21 is also one that's affected in Down syndrome. Trisomy 21. What was the question about Down syndrome again?
How the gene mutations that were presented today play a role, or may play a role?
I think once you have a chromosome changes that contains so many genes, right? And they usually have other comorbidities from early on. So that single base pair change, the misspelling in a book, is applicable for many individuals with no other comorbidity but epilepsy. But I think chromosome abnormality is that often causes intellectual disability early on, global developmental delay. So I think good example is trisomy 21. That's the one that we understood best early on.
Another question we have is, if treated early, according to the genetic profile of the individual, can intellectual disability or delay be prevented?
That's a good question. There's always a debate. So to the point where we decided to change the name of early epileptic encephalopathy to early epileptic and developmental encephalopathy, because I think sometimes the gene itself, it's one event that causes both. So I think Rett syndrome with MECP2 is another example where the chromatin changes in the epigenetic influence changes so many genes, and they have the loss of hand function and hand use, in addition to epilepsy. So it can come together. But I guess the focus has always been the gene is something you're born with that we cannot change. What are the things that we can make a difference, right? And I think I showed the example of Dravet syndrome. When Dr. Dravet initially wrote a paper on her, I think 17 children, she said 100% had mental retardation by that term at that time. So profound intellectual disability, 100%. Now we make diagnosis after first or second febrile status epilepticus or hemiclonic, continuous prolonged hemiclonic that changes size and seizures are triggered by temperature, recognized as SCN1A. I have made diagnosis at 8 months, 1 year, and they finish, some of them finish high school with flying color. I mean, I don't know if it was a other genetic composition of that child, but I see doing much better than what Dr. Dravet has described. So I feel that yes, sometimes you can make a difference, but often it's a what we call essential comorbidity, where they come together.
Thank you. We have a question from a couple of people about whether or not whole genome sequencing incorporates all the information that microarray and whole exome testing would, and more. If whole genome testing is done, would microarray and or whole exome testing potentially yield any further or other information of value?
Whole genome sequencing is the future. Yes, it is part of the, when you order whole genome sequencing, it will do microarray plus all, and it's a different platform, but yes, it will be inclusive. The trouble with whole genome sequencing, now we have information overload, and we don't understand the introns as much or regulatory elements as much as exome. Exome is the one that translates into messenger RNA and then into the protein. So even whole exome sequencing sometimes is difficult to interpret. That's why we do whole gene panel, which is much faster. You get the answer in 6 weeks. So the science is not there yet to allow us to interpret the information in whole genome sequencing. But I think more and more we are focusing, we're trying to do whole genome sequencing because information is all going to be there and we'll be learning together. But the knowledge is not there yet, hadn't caught up. So the clinical translation is far behind. So that's why I focus on epilepsy gene panel, at least for children with epilepsy, early onset epilepsy. Yield is high, the answer is quick, and we're not even there yet. Nobody, so many adults with epilepsy and intellectual disability never had epilepsy gene panel done. And so I'm looking at this low-hanging fruit. Let's do that. But you can then, of course, whole genome sequencing will be all-inclusive.
Thank you. And one related question to that, I think, is in terms of going beyond the testing lab interpretation to having second or outside interpretation of the raw data. Or should one do that or get it done is a question that's been presented.
So there is a NIH-funded program about the rare disease, and we had one child where everything was negative and we were desperate. He had an Otohara syndrome and was sent over. We were enrolled in that NIH program and we got the answer. So there are times when that can be done. I think it's important to connect with genetic counseling. So these are the subspecialists of human genetics. They are an amazing resource. And I think most human genetics department will have genetic counselors, and they are the probably the best resource for up-to-date information. Where can the test be done? What's offered? and they have access to this amazing web-based knowledge that they will be able to be informative. So we should tap into their expertise. I do.
There's a question on about the CACNA 1A Foundation. Does your foundation cover the cost of genetic testing for adults whose insurance doesn't cover it?
We'd like to. No, we unfortunately we don't have the ability to do that right now. We do fund, obviously, you know, we raise money all day long, all the time, but that's really to support research. And so we have this, and that's why we did this collaboration with Probably Genetic. Typically, when someone comes to our website, it's because they already have a diagnosis. However, if you look on our website, which is www.cacna1a.org, under I think it's under the resources section, it will say, could it be CACNA 1A? And that's where you can, if you've come to our website because, or maybe you know somebody who fits the bill, has developmental delay, you know, epilepsy. Not all of our patients actually have epilepsy, but they all have ataxia, which is a balance and coordination disorder. So if you know of an individual that has some of these symptoms, then I think it's worthwhile going to the Probably Genetic website. You can access it through our website, as I mentioned, and fill out their screener, and perhaps you would have access to free genetic testing. You fill out the screener, they will connect you with a doctor a physician who will go through, because it has to be ordered by a physician. So they have physicians that can do all of that for you. And it's interesting because before we started this collaboration with them, they had found through another family patient advocacy group, they found 3 patients with CACNA 1A who came in through a different organization. So they're finding patients, and that's really what it's all about. We need to find, we all need to find patients. All patient advocacy groups need to find our patients. And so this is really a great way to do so. But unfortunately, we don't have funding for that yet. But but we're happy to help families access it. So, you know, please feel free to reach out to me.
And there's one more question about, do you have a succinct description and data summary that could be shared on social media to urge and to educate all the beneficiaries of the type of genetic testing, positives and negatives, in a plain language for us to understand and their families? And then also a message for encouraging potential study participants or patients that are needed, as was discussed earlier.
So as far as the CACNA 1A Foundation is concerned, I will ask you to please go to our website, sign up for our newsletter. We send out a monthly newsletter, which is chock full of information. And there's also links to our social media handles. And this is something that we're working on all of the time. So it's really at the forefront of what we're doing.
And I agree with the person who asked the question. This needs to be, the words should be out, how important it is to get genetic testing done, especially for adults. And I think it should be one of our project going forward. I'm very grateful for that idea. I think many pediatric epileptologists, pediatric neurologists are very aware and will do it. And we are very much benefited from no cost to family, younger than 8 years. We can order without having to go through the prior authorization with insurance companies. But I think for older individuals, and they feel the barrier, I think adult providers find a barrier, and they're not convinced that it is necessary. So yes, I think we have to find a way to spread the words.
Baker, can I just add a point? Hi, everyone. I'm Seth Keller. I'm helping to put together this webinar series, and I just want to give a major super shout out to our wonderful speakers today and all my colleagues who were able to put all this together. And I think the issue is that we're all in this together as a team. And in terms of really the questions related to getting the word out, AADMD, who certainly sponsoring this event, ILAE collaboration for this event, American Academy of Neurology, the section of adult with IDD is behind much of this. this. So really, your voice and your mentioning of what these things are absolutely what we thought about. Just one real quick thing in the interest of time is that inside the American Academy of Neurology, the issue about genetic testing and the approval, well, it's always a pediatric focus. That's really it is. And the reality that we formed our section of adult IDD, because basically no one knew many years ago people would grow up and live long enough. Unfortunately, now they're living longer. We have to advocate, and that it does include genetic testing for those that are now in their 30s, 40s, 50s, and that's what I do as a neurologist. So we actually did have a meeting within the AN just in this past year, coordinating within the AN and the payment structure and the neurogenetics section about the importance of this. One thing that was really looked at is that they didn't know what they didn't know in terms of the problem. They really didn't know there's even a problem to know. And they're very cynical and jaded about, well, why do you need to know? And why is it going to change? And, you know, all those kind of rhetorical or not questions. So we really kind of went at it. But I think anything that we all can get from this audience and others that help us drive this message, we're going to continue to do that. But again, I really want to thank everyone, and also Jazz Pharmaceuticals. And I don't know if there's any other questions, Shaker, but were there anything else you got?
Well, time's up.
Time's up. So I wanted to also let people know that this is going to be archived for those that are now want to listen to it. And we have another one in our wonderful ongoing series. We have one more. We have one more webinar on August 17th at noon Eastern time. Behavioral comorbidities. How important is that for issues in epilepsy? Huge issue. We're having a wonderful speaker, Dr. Marco Mula. Excellent. So stay tuned, wet your whistle on that one. But again, thank you. And also for my colleague behind the scenes, Jamie and Courtney, really thank you again. So all have a great day and really appreciate you tuning in. Thank you very much. Bye, everybody.
Thank you.
Thank
Thanks
you.
all. Bye-bye.
Bye.